So I'm going to cover dialysis and in general renal replacement therapy. You should have already, or maybe shortly after this, we will have a lecture with acute renal replacement therapy. So we have two types of renal replacement therapy. Today I will tackle the topic of renal replacement therapy for the chronic patient. A completely different topic is the renal replacement therapy for the acute patient, and that is more applicable to the in-hospital setting. Now, I know that you're mainly interested in the in-hospital setting, so as I navigate through this, I'm going to make references to what we encounter on the wards, but this is mainly for what we see as primary care physicians in our clinics. As nephrologists, we get these referrals from you. So it's this interaction between you and us, you referring patients and us getting the patients. And so how can we provide the best care to the chronic failing native kidney into replacement therapy, either with transplant or with dialysis? For the acute part, again, it's a separate topic, AKI, and that will address HD versus CVVH. I won't touch much on CVVH today. Mostly will be HD, and as much as I can, I will make some references to the acute part that we see in the hospital. They are somewhat alike, right? The acute hemo and the chronic hemo, they're the same machine. They use the same machine. They use the same solution. They use the same prescription, if you will. In fact, prescription is a little bit different, right? Heparin, for example, it's rarely used in patients because of risk of bleeding. These people go to surgeries often. Outpatients, you're almost obligated to use, otherwise they'll be very anemic. They'll use so much blood by not giving, it's counterintuitive, but not giving heparin means your microfibers, imagine like a couple of thousand of tiny straws into that casement, hard casement, plastic casement. Imagine that being clogged with clots, with clumps, with platelet clumps and microclots. That's why heparin prevents that. So it keeps the blood flowing. It's very important. So heparin, it actually prevents anemia in chronic dialysis, whereas in acute, it could cause HIT, or you could give it to a patient with HIT or a patient with liver failure, extreme thrombocytopenia. You may give it to the wrong patient. So we tend to, or a bleeder, GI bleeder or intracranial bleed. So we try to shy away from that a little bit in the inpatient area. So having said that, let's start with prevalence and forecast of this ESRD. A little bit outdated slide, but you can see starting in 1978, at the very early stage, primordial age of dialysis, and getting through the 2000s, the last 2 decades, and the projection of the next decade, you can see how this is supposed to develop, to really increase. And there's a couple of factors. They survive better. We are much better in the last 2 decades. We've finally been able to make a little dent in that huge mortality. So they live longer, so prevalence is higher. They will be living on dialysis. Even though incidence perhaps plateaus, the prevalence will increase due to this increased survival. As we increase survival even more, we project a pretty much skyrocketing of the number of prevalent dialysis patients. So therefore, very important monetary or fiscal issue for Medicare, very important social issue, very important medical issue for us. Objectives today to describe treatment options for renal replacement therapy, understand the principles of these dialysis modalities and the transplant, and compare the outcomes, importance of residual kidney function in all these equations, and to describe kidney transplantation process a little bit. So think of a case from the clinic. This is not really supposed to be a 10-slide presentation. It's just a 2-slide description of a typical patient with a failing kidney, with a failing native kidney, 39-year-old African-American man, no past medical history, except this kidney issue. He's got 4+ proteinuria on a dipstick, lower extremity edema, hypertensive on routine exam. You see him in clinic and you refer him to nephrology. Let's say, so initial nephrology visit, exam is unremarkable, except he's got a BMI of 33. His weight is 230 pounds. His blood pressure, it's a little bit better, than the previous one we listed. He's got this 2+ peaking edema in the lower extremities. He's treated with, let's say, hydrochlorothiazide lisinopril combination. His laboratory data shows hypoalbuminemia, a total cholesterol close to 400. So there you go, you know, with edema and everything else, your 4+ protein dipstick, you will think this is nephrotic syndrome. You know, serological workup is negative. You do, again, the urinalysis, you do see no RBC, so it doesn't seem nephritic, although he has a little bit of hypertension. Creatinine is abnormal, seems more nephrotic. The spot urine protein to creatinine ratio, 10 grams, 10,000 milligrams, right here by the ratio. The GFR, I want to make a very quick reference, is 37, but I want to make you aware, I urge you to go to mdrd.com. This is a website that, you know, you can enter the sex, race, and age of the patient and the creatinine value, or cystatin C, which is another marker that we use often. So by entering either one or the other, cystatin C or creatinine, most often creatinine, we get the GFR right away. And you know, you don't need any weight, anything else, but it gives you this type of GFR, 37 cc per minute per 173 meters square. So that means you have to know body surface area. I calculated for you, this gentleman's body surface area was 2.2 to 2.3, depending on the equation used. So that means that his GFR is actually, if you correct for body surface area, will be 47 to 50, depending on what body surface area equation you use. So what this tells you is that GFR, as it is reported by LabCorp, Quest, and all the labs, it's per 173 meters square. So pay attention to that. MDRD.com will give you the same number, but then there is, I think in the bottom, there's a button where you can actually do the correction automatically and enter the body surface area or the height and weight of that patient, and you'll arrive at the real GFR, which could be surprising. Look at this patient. It says 37, but actually his GFR is 50 perhaps. That's the accurate GFR. He's a muscular young African-American. So per his 2.3 square meter, he's the whole person. I mean, he's not just 1.73 of him that we're looking at. We're looking at whole of him, and the whole of him has a 50 GFR. Well, of course, then no surprise, he has no anemia, because anemia tends to happen later in the disease when the GFR is perhaps towards 30 or below, and he's got no hyperphosphatemia, although they don't give us the phosphorus. There's no metabolic acidosis, etc. So you see, that's just a little aspect I wanted to touch on. And going forward, he got a kidney biopsy, perhaps the second visit with us, and we showed that he has FSGS. So initial presentation, hypertension, CKD, proteinuria, nephrotic syndrome. He's on a diuretic and an ACE inhibitor, gets a biopsy. He shows FSGS, has 10 grams of proteinuria. We do the best we can. And of course, I'm not going to go into, is this primary, secondary FSGS? What did we do? Is he going to go on CellCept or prednisone or combination? No, I'm just looking at the big picture here. Diagnosed in 2000, and we're going over 8 years. And we have a decline in GFR. And now, for simplicity, we're just going to look at the 37 of GFR. So that 37, I'm sorry, I'm trying to see. Okay, I apologize. So here is the 37 is right here. And he's failing over 8 years to a GFR about 7. So a delta of 30 points of GFR loss over 8 years, that's about 3.7 or 4 GFR per year. So 4% of GFR per year, that's a rapid loss. This is typical for glomerulonephritis. If it was diabetes, you would expect about a 2 mil per year, according to most study of GFR loss. And then if you had hypertension or just a chronic interstitial nephritis from a bad pilo case when they were young, that one is even more stable with 0.5 mil to 1 mil per year of GFR loss. So the steepness of the curve, it's attenuated in those conditions. So even diabetes tends to fail a little bit slower, although sometimes we see in uncontrolled diabetics a very big falling off a cliff phenomenon as the GFR approaches between 20 and 10. So it becomes very unpredictable at that point. But here is a rather predictable, rather linear drop, about 4 ml per minute over 8 years. Very common scenario. It reaches ESRD, and there we go. We have to confront this question and basically start our discussion for today. So indications for renal replacement therapy are a little bit different in chronic clinic setting versus acute ICU or medical ward or emergency room setting. Hyperkalemia, I'm going to talk mainly about the acute the chronic indications in the clinic. So hyperkalemia, you may argue now with the advent of the new potassium binders, Lokelma and Veltassa, we can resist this problem for a longer time. Metabolic acidosis, we have things like sodium bicarbonate, other things that can tackle this issue. So it becomes unmanageable. Both of them can become unmanageable at certain points. So therefore, there are indications for replacement therapy. Fluid overload, as we know, recurrent CHF admissions, uremic pericarditis, of course. Other non-specific uremic symptoms, nausea, anorexia, impaired nutritional status. And that's a big one. Impaired nutritional status, meaning an albumin that continues to fall. And make exception for this particular patient. He has nephrotic syndrome. Let's say we treated him acutely with steroids, and he responded, went into full remission. Still, he continued to decline because he's got this chronic FSGS, but not proteinuric. So his anemia, his low albumin will be, when he reaches GFRs of 7, as we saw in 2008 on that graph, when he reaches such a low GFR, he will have a malnutrition basically due to his nausea, chronic uremic symptomatology. At that point, we try to add nutritional supplements, most often Nepro. And if we fail with the maximal intervention to address this issue, antiemetics, Nepro, etc., encouragement, family support, all this may fail one day, and that's another big indication. It's the albumin going from 4 to 3.7 to 3.3 to 2.9. That's a big red flag. We have to start dialysis. Despite, of course, a compliant patient going to nutritional consultation and doing all his Nepro, etc. Increased sleepiness, decreased energy level, attentiveness, and cognitive tasking. Performance at work is impaired. They start missing work, etc. So what are the treatment options? So we have, of course, the dialysis options. We have the kidney transplant option and the comfort care. We have to address all of them. There are arrows going in various directions here, right? From kidney transplant, you can fail kidney transplant, go back to peritoneal dialysis or to hemodialysis. A dialysis patient like ours could go first on dialysis, but then get a transplant. So you see, they can go first on peritoneal dialysis, and later they can fail that technique, or the membrane, their internal peritoneum can fail, therefore has to go to hemodialysis, and vice versa. They go to hemodialysis, they don't like it, it's crowded. Now with coronavirus, why wouldn't they stay home and do PV? So there we go the other direction. So you see how complex this is. And of course, preemptive transplant, perhaps that's why this is red, pictured in red. Kidney transplant as a preemptive option. As you reach ESRD, do not go to any dialysis, but go to kidney transplant. We will see this is the best treatment option. It gives you the best survival. So going to dialysis option, we have hemodialysis and PD. Of course, hemo can be in-center, the conventional, as we call it, conventional HD 3 times a week, or home HD. Could be nocturnal, very powerful, done over 7 to 8 hours during sleep. Short daily, usually anywhere from 2.5 to 3.5, 4 hours of treatment, done up to 6 or even 7 days a week. Peritoneal dialysis, CAPD and CCPD refer to the fact that CAPD is continuous ambulatory PD, meaning that patient does all the exchanges manually, and CCPD is the automated one, which is cycler, continuous cycler peritoneal dialysis. It's some technical designation to indicate that this machine is used to assist patient here. And those are done at home, of course. So this slide shows you the incident patient counts according to our big Medicare maintained registry called USRDS, or United States Renal Data Systems. Every incident dialysis patient has to go into this registry. So now they're counting these patients by first modality, and they look at how many got transplant, how many got PD and hemodialysis. You see that this line here denotes the hemodialysis. This is total dialysis, the one above, and the PD, it's the very thin or the very low number of patients, unfortunately. So it's an underutilization of peritoneal dialysis. The transplant, even more disturbing, it's barely there. It's a very low line, meaning the counts of those transplants are very, very low. And this is for incident ESRD, first treatment. So in other words, this is not total number of transplants. This is just the transplants that are preemptive. It's the first modality of treatment for ESRD, being transplant. Very, very, very low, which is the best option. So it tells you that only extremely low number of patients have access to this, or luxury to afford transplantation as a preemptive option.
I'm sure this is a tough question to answer. I'm sure there's many reasons, but it doesn't seem like that has changed at all over decades. Why do you think that is?
Yeah, yes. So transplantation, preemptive transplantation, there's several factors going into this. It's availability of living donation. So that has not increased. That has been stuck at a certain level. Despite, community education or efforts of, improving, putting, doing all sorts of education, and as well as, I think the other thing is cadaver transplant. That has been a little bit more successful in different countries. I think Spain had a big success with the making almost mandatory for people to answer that question, the driver license. A lot of people there culturally also, believed in that. And so I think that was a big increase in the, in the incidence of cadaver transplants. But for United States, but again, cadaver transplants are, to get a cadaver transplant preemptively, you have to be listed for the amount of waiting time there is out there. So now I think most blood types, blood groups have a waiting time to 6 to 8 years. So if you have to be listed for 6 to 8 years prior to your kidney failing in order to accumulate the necessary points to qualify for a cadaver transplant. So very few people list so much in advance, just those with a very low, almost horizontal slope, like a very slowly tilted slope for loss of GFR. So those relatively stable patients, they get, but they're a minority. The diabetics, the GN patients, they fail rapidly. They don't have enough time to accumulate. But again, it's cultural for the living donor, and for cadaver. We did increase cadaver, especially recently with the Hep C, B positive kidneys being available. The problem is, even with those, the wait time is the same. It's so many people on the waiting list that die basically waiting for a kidney. So that's why that huge wait impairs or precludes many more than that small percentage of patients getting a preemptive kidney. So let's see. The CKD education, again, education is big on all these levels. In particular, we are going to see these slides a few more times, and the reason I'm showing again this decline of GFR is because at some point along this journey, we have to decide, when are we going to refer this to nephrology? Hopefully as soon as possible. That and rightfully they did that. I mean, correctly they did that in this case, and they referred it to nephrology clinic very early. We biopsied, etc. Even diabetics, everyone, we should look at their GFR, we cannot possibly take care of all CKD3A patients, which are GFR of 60 down to 45. There are several million, and it's not possible. But there are select cases that you refer for certain issues that are perhaps difficult to control, hypertension, hyperkalemia, that seem to be controlled. They're not referred to us until later. However, this one shows the 40 to 30 GFR. So, 45 to 30 is CKD3B. Of those, there's still millions of them. And so maybe not 15 millions, but I think 7.5 million still. So I don't think we can see all of them either. But again, in this case, it's a GN. So these cases get referred to us. So again, early referral to nephrology, and perhaps it's too early at 45, even at 35. We will see below 30, it has to happen, because then we're getting into the issue of access, into the issue of transplant listing. But above 30, it's a judgment call for each PCP practice. Around this line here is when we really have to start doing CKD education, whether it's a good PCP practice or a nephrology practice. We have to start very aggressive education for CKD, meaning how to get them early listed for transplant, and then also how to get early access. So education will include vascular access discussions, peritoneal dialysis, mentioning the quality of life advantage, very, very important. A lot of people, it's underutilized modality, the PD, and people do not understand what they're missing, really. And there are a lot of people that are qualified. Sure, there is those with mental illness, those with incapacity, physical incapacity, they cannot do it, but a lot of them can and just don't do it, not knowing what they're missing. Kidney transplantation need to be referred around GFR of 20. We do refer in our practice, I think all of us do refer a little earlier than that, like maybe about 20 to 23. If it, there are multiple, as you know, GFR is so variable, it dips below 20 one month and it's above 20 the other month. So as long as it's approaching 20, 21, I refer them, and our transplant group takes them under their scrutiny. And then by the time they complete their workup there might be 6 months or so, they'll be listed. Living kidney transplant, educate them about that. Family, friends, and altruistic donation modality. Build time on list before dialysis, discuss about that. And then even transplant, so the preemptive transplant being the modality, the best modality for survival, both of person survival and graft survival. So patients with ESRD, remember that this is a very forgotten topic. Almost, I don't know, it's a huge percentage. I shouldn't say almost 80%, but I think a very large percentage of patients, they don't have antibodies for hepatitis B as they come to dialysis. They have to be protected as dialysis patients because of transmission. And this is a CDC, mandatory CDC guideline where your HD patient has to be vaccinated for Hep B. Those unvaccinated patients or those without antibodies are extremely prevalent. The reason is we forget to vaccinate them, CKD4, stage 4 and CKD stage 5 before reaching ESRD. Either they go too fast through those stages or we just simply forget. That's why this is one of my preferred slides. And remember, if you let it up to us when we get them on dialysis to vaccinate, they have a very poor response. Only 50 to 60% of them develop antibodies, compared to over 90% in patients without renal failure. So vaccinate them early, knowing that they will end up as ESRD patients. And they end up having lower titers and protective levels for shorter duration if they're not vaccinated. So we're missing a big opportunity there. So a word about native kidney function. That obviously performs a lot of functions, including handling of salt, handling of volume, blood pressure control, removal of urea, creatinine, phosphorus, etc., so-called urinic toxins, maintaining electrolyte balance, involvement in bone mineral metabolism, homeostasis, metabolism of small molecular weight proteins, control acid and base balance, even handle protein-bound, some protein-bound proteins, and protein-bound solutes, and such as indole acid, indoxyl sulfate, and picresyl sulfate, which are very toxic compounds, end products of bacterial metabolism in the gut that get absorbed and then eliminated by kidney, they build up in dialysis patients and are very protein bound, so it's very hard to remove them with dialysis. The kidney is a very active metabolic site. We know that it metabolizes insulin. It's a site of gluconeogenesis. It metabolizes glutamine. Glutamine is a major fuel that the kidney uses to develop the NH3, NH4 plus acid-base control system. One of the titratable acid, the ammonia type of buffer, which is key in control of acid base. The production of erythropoietin, of course, and production of hydroxylation of vitamin D, just to mention a few. So solute removal, of course, it's a key function. Most solvents are filtered at the glomerulus and then reabsorbed in the tubules. And this reclamation process is very similar to our CRRT or hemofiltration process that we use. So it kind of reminds us of that. The creatinine is filtered and secreted. Some substances are doing that. And we have the organic OAT and OCT, which is organic anion and organic cation transporters, which actively shuttle anions and cations, secrete them actively into the lumen of the tubules. And that's very important. It does that with a number of medications, with a number of toxins. That's why it's important to preserve residual kidney function, because losing those will lose something irreversibly. There is no dialysis modality that can do those active shuttling of the function of an organic anion or cation transporter. There's nothing like that in a dialysis membrane. And we talked about metabolism. So here is the analogy with hemofiltration. This reclamation is like you're filtering, you're throwing away all that fluid that goes into the sink in the ICU for CVVH ICU patients, and then we are reclaiming that naturally for us is just having these engines of sodium reclamation that drags and water and all these things being reabsorbed. In ICU, of course, we're just giving them replacement fluid, those big bags laying by the sink in the middle of the nursing station. So those are the reclamation. In other words, that's the process of reabsorption in our CVVH world, which you have to give them as IV fluids, as we waste equally large amounts by draining them out. Fluid effluent, CVVH effluent full of toxins. So same idea, we're trying to copy to, it's a plagiarism that we're trying to do to a very, very ingenious, naturally occurring system. So the next idea is to cut a little bit of hemodialysis. So we can see here a hemodialysis apparatus with here having the hemodialyzer where the filtering takes place. There will be an arterial and a venous line. And you can see here how the cannula go usually facing away from each other to minimize recirculation. And this is the direction to dialyzer, from dialyzer and connecting to the apparatus. So you can see that, so zoom in here. So what happens inside the dialyzer? And I wanted to jump one more slide. This is the dialyzer. This is a hard casing. And here is, imagine several thousand Starbucks straws, if you will, that go into this structure. Here is a resin that seals them very tight, and they pierce through a floor. There is a floor right here, and they pierce over through the floor. And here is there is a cap that gets screwed on top here, and here will be blood. In between, like on the other, in the middle here, it's all fluid, and we have the inlet and outlet of the dialysate fluid, and here is the inlet and outlet of blood going through these. So it's a completely sealed system. There's complete separation between blood and dialysate. And in between is this usually about 2 square meters of membrane. If you were to cut open all these straws, they amount to about 2 square meters, a little bit less or more depending on the dialyzer size that we prescribe. So you see here, dialyzer goes into the filter below that screw-in cap, and then so the dialysate circulates this way, and then the blood comes counter current to the dialysate from that very end in the long axis here to this one here. And again, these are resin, some very, very tight, it's almost like a wax or resin or something that completely, it's a plastic, it's a very resilient substance that will completely seal the, if you will, it makes it, think about your, say, a vent going through your roof, like, you know, the vent that goes into, you know, say your bathroom vents, and then this has to be sealed, otherwise it will rain inside your house. So, you know, it's very tightly sealed here. So the blood from this compartment does not go back into the compartment where the dialysate. It's actually like a swamp here in between all this, all these straws. They are floating in dialysate, and here they're again very sealed, very tightly sealed, and they are peeking through this surface and then collecting all the blood through this collecting cap. So that's how it works, these dialyzers this day and age. And of course, here is another view. This is the you know, all this semi-permeable membrane and the fresh dialysate, the toxin-rich blood, and the way how this exchange takes place. Another view here is a graft. It's made of polytetrafluoroethylene, or PTFE. You'll see that in our notes and vascular surgeon notes. When we talk about grafts, we say PTFE. Graft is the material it's made of, and this is a native material. It's a vein and an artery of the patient. Here is the tunneled catheter. There is a cuff. You'll see the term tunneled dialysis catheter, perm cath, or cuffed dialysis catheter. That, you know, for the board question, for your purpose of reading a note, these are all double lumen cuffed hemodialysis catheter, or tunneled or perm cath hemodialysis catheter. Of course, as opposed to that, we have the non-tunneled ones, that the trialysis or the double lumen vas cath or Quinton catheters. Arteriovenous fistula is the best type of access. And so here I kind of give you a hint already, but the question says, which type of vascular access is associated with better outcomes in hemodialysis patient? And it gives you temporary catheter, AV graft, fistula, and tunneled, or I'm sorry, this is tunneled and this is temporary. And of course, this is the worst. This is the worst. The tunneled is a little bit better, but still terrible, because it's a catheter exposed to infection and clots, etc. And the AV graft and fistula, this is the question. So basically fistula, it's much better in terms of outcomes. Which vascular access and when should we place that? Again, about 20% of GFR is when we should place access. It is happening rarely, that I will tell you. Patients are undecided. We're trying to steer them all towards PD, and then some of them say, I've heard there's something else rather than dialysis. We don't like dialysis, we hate dialysis. So that way they prolong this as much as they can towards when they crash into dialysis. It's very wrong to do that, but if they have enough time, when they get to about 10 or 7, whenever they approach that point of starting, we have a few months to place the PD catheter. It takes only 3.5 to 4 weeks for that to mature. So PD catheter, it's an easier thing, but AV fistula takes about 4 to 6 months to mature. So it will be necessary to place, at least, if not here, at least somewhere here. It is difficult conversation. This is adjusted relative risk of death by type of vascular access, and you can see that in prevalent and incident dialysis patients, this is the relative mortality risk if they are diabetics. So in diabetics, the worst mortality was in people with catheters, and in non-diabetic, I'm sorry, so here is the incident diabetics with catheters, grafts, and fistulas, and this is the incident non-diabetics with CVC, graft, and fistula. So you see that fistula has the lowest mortality in both of those groups. And in prevalent patients, the same thing, the lowest mortality in AV fistula. Here, interestingly, diabetics have a relative risk of death. The ones with grafts have even higher relative risk of death compared with CVC if they're diabetics. So the main problems with AV grafts are that they clot and they get infected, especially in diabetics. Infection in grafts, it's very common situation. Patients who started using AV access by timing of first referral to a nephrologist, look at time from initiation of dialysis. This is 6 months since they initiated dialysis, and these curves show how many months did they have a relation to the nephrologist before they started, for how many months they have this relation with the nephrology office. Less than a month, 1 to 4 months, 4 to 12, and over 12. So the best results in over 12 months being enlisted with a nephrology practice. And this is patients who started using an IV access, graft or fistula, and this the percent of those patients. So the best percentage, 50% and higher, it happens in these people that were with a nephrology practice for a long time. If they're less than a month, it's very hard. It's obviously the worst situation. The nephrologist doesn't have time but to place a catheter. So vascular access guidelines, I'm going to go a little bit faster so we can do, this is an important slide. So we have to preserve arm veins. We should, especially arms, we try forearm, arm altogether, but arm becomes extremely important, particularly the cephalic veins in the non-dominant arm. They should not be used under any circumstances. That's why we always tell you, do not allow these PICC lines to be placed, even peripheral IVs. So dorsum of the hand could be used for IV, should be used for IV. A medic alert bracelet should be worn to inform hospital staff to avoid IV cannulation of essential veins. And subclavian vein catheterization should be avoided for temporary access in ICU patients because it leads to stenosis and precludes use of ipsilateral arm altogether for access later on. So we can see the guideline with the bracelet should alert anybody with GFR around 30 or less, no BP measurement on the arm, no IV, and no blood draws. We prefer to avoid that in non-dominant arm as much as possible on both arms. Moving on to PD, so peritoneal dialysis apparatus. It shows you the dialysate, the bag containing dialysate being hung here. This is a manual situation where it's not done through a cycler or an automatic machine, but it's done manually. So from the pole, infusing through the Tenkov catheter into abdominal cavity of the patient, and here dwelling. This is number 2, stage 2, dwell for 3 hours, usually 3 to 4 hours, and then it's drained out. This is takes about 5 to 10 minutes, average of 10 minutes, 7 to 10 minutes to drain in, about 15 to 20 minutes to drain out, a little bit slower. That's under normal circumstances. Constipation makes these processes much slower, both infusion and drainage. Sometimes malfunction, mechanical malfunction of catheter. The number 1, 2, and 3 cause of that is constipation. Make sure you empty all your PD patients before going to procedures. So when they're going, even for anything off the floor, colonoscopy, any surgery, any other diagnostic procedure, they should be empty. If they're not empty, transient bacteremias are much more likely to seed because this is a very, very glucose-rich culture medium for bacteria. And this is the bag that collects the dialysate, spent dialysate fluid. The principle of PD is that we have a little bit of a negative pressure here in the abdominal cavity, inside the blood capillaries, in the mesenteric area. We have a little bit of positive pressure, of course. Water moves through the aquaporin channels. There are 3 types of pores. We don't have time to cover that in PD. One of them is aquaporin, super fast transit for water. And then we have, these are blood cells, of course, that do not pass. And the positive pressure helping for this movement, and it's a convective clearance with solvent drag and washing many solutes to the other two type of pores, which are the large pores and the small pores. So the abdominal, the visceral mesenteric area, peritoneum, acts as a semi-permeable membrane. These are some types of PD catheter, the original Tenkov catheter, the coiled PD catheter, most commonly used. This is a swan neck Missouri catheter, and this is a Toronto Western Hospital catheter. This is an image, a laparoscopic image during placement of the catheter. Catheter should rest in the right lower quadrant, in the true pelvis. These are some exit sites, possibly. If there is, people with obesity should not have the catheter exit on the lower area of their abdomen where they cannot see the exit site. Exit site should be on the upper area or in the chest area so they can examine, clean, and see that catheter exit site. Very important. This is very common mistake by inexperienced surgical practice that perhaps places very infrequently catheter. That's why we should have a to-go practice where all your PD patients should be handled by the same practice where they have these best demonstrated practices in place. People with mental Down syndrome, we had patients with Down syndrome that their family elected a PD for them. And so typically this can be as long as you want, and the surgeon can tunnel it in the back in the interscapular area. And so they don't reach, they don't pull the catheters out. So in that type of situation, just to mention that. And PD catheter exit site, aspect, normal exit site without redness, without any crusting around it, without any other sign of erythema. PD, it's continuous and intermittent. These are some types of PD during the day, multiple ambulatory exchanges done manually every several hours. And here, one long one at night. We do this in the hospital, as you know. The cycler machine can do back-to-back exchanges at night. This stands for CCPD, or continuous cyclic or cycler PD, meaning the machine assisted. Here you have slightly different situations. For example, very frequent, very short 1 hour exchanges, times 7 or 8 of them in people that are rapid transporters, because those patients get fluid overloaded if we don't drain their fluid quickly. This is the apparatus. And what is the most common cause of technique failure in PD? So that, I will tell you, is peritonitis. Peritonitis is much more common than any of the above. Yeah, they get malnutrition, is true. Their albumin drops because it's like an abdominal washout several times a day, where you wash a lot of fluid, peritoneal fluid that is normal peritoneal proteins are there, and you wash them out. It's just unfortunate that that happens. Normally those will go back into the lymphatics and return to your SVC. They cannot do that because they're washed out regularly. So you do get develop a little malnutrition with a low albumin. Peritonitis by far the most frequent problem. Non-adherence to treatment regimen, it's a problem. And ultrafiltration failure, usually after 2-3 years being on PD, it happens occasionally. So 25% of PD patients switch to HD within 5 to 7 years. And interestingly, 60% of PD patients are not doing PD at 2 years. So in one study, at 2 years, 60%, 60 out of 100 patients are doing something else than PD. And unfortunately, a small proportion passed away. Bigger proportion got transplanted, which is great for them. And then the remaining go to HD. And so this switch to HD, are the reasons for that are psychological. Well, let's start with the more common, peritonitis, then ultrafiltration failure, malnutrition, abdominal surgery that precludes further use, ventral hernia, etc., and unrepairable ventral hernia, for example, and psychological issues that force patients to become, not not be a candidate. So which dialysis modality provides the best outcome? We look at, is there any contraindication? First of all, can we do this modality X, or we can't do? Survival, it's a big question. What's the best from survival perspective? If that was, the evidence was out there, we would put everybody, it would be malpractice, right? Not to put someone on that modality that provides survival, but there is no modality that provides survival over, except transplant is the only one. So the other ones are equivalent. Quality of life, yes, that's big difference between HD and PD, and treatment satisfaction as well. So I will start to look very briefly into contraindications. Loss of peritoneal function through extensive abdominal adhesions, and we'll have a picture on that in a minute. This limits dialysate flow and also pose a very unique danger. I will show that slide now. According to the surgical data, these frequent adhesions pose the risk of herniation of a bowel through a triangulation between some of these adhesions and the PD catheter itself. So there is an area where you can have a herniate, strangulated bowel hernia through that triangulation area. So it's very dangerous. Their surgeons try to not, to declare these people not suitable for PD if they see a large number of adhesions that cannot be managed through lysis of adhesion. If they can, they lyse adhesions and then they place the PD catheter. So I wanted to mention that there are uncorrectable mechanical defects such as diaphragmatic hernia. Mention that there are persons physically or mentally incapable of performing PD, so we have to be really aware of that. So survival, and this is important to say that there is no prospective randomized clinical trial that shows survival benefit for PD versus HD or the other way. There are significant barriers to perform such a study, and we're left with the analysis of good observational data. We have this good study over 8 years from Ontario, Canada, with incident elective outpatient starts, about 4,500 HD and 2,000 PD patients roughly. No switching between modalities, and based on an intention to treat baseline modality analysis. Here is the Kaplan, survival probability. The curves do not separate. It's a for the adjusted peritoneal dialysis and HD curves. They fail to reach statistical significance at 8 years. So a pretty good study, although not RCT. There are biases, residual confounding, limited adjustment for known factors associated with high mortality, and lab data associated with high mortality. Short follow-up, only 1 to 2 years in some of the studies. Lead time bias, and this is one of the important examples of lead time bias, is that, our lack of baseline creatinine, we don't know, screening versus, so when you talk about the onset of this ESRD, it's a very complex, oftentimes confounded variable. Selection bias, patient characteristics play a role there. Statistical methodology, center effect, confounding by clinic, as patient characteristics vary by center, from academic center to academic center performing these studies. And then how to handle the modality switching as treated versus intention to treat also complicates things. So in considering choice of dialysis techniques, other issues should be considered, quality of life in particular, and treatment satisfaction. So we have PD patients report better quality of life, invariably almost, in bodily pain, travel, access to travel, diet restrictions are less, dialysis access, it's less of a headache, financial well-being is better, physical functioning is, questionnaires are better. And at 1 year, patients on HD improved more on aspects of general health related quality of life than patients on PD in this choice quality of life PD versus HD study. HD patients had greater improvement of physical functioning, sexual functioning, and general health perceptions. Factors influencing dialysis choice, also, treatment satisfaction and late referral, etc. So for treatment satisfaction, they they're more, PD are more likely to rate their modality as excellent, give excellent ratings. Also, there are studies with nurses and physicians that they say that they will choose or choose that for them or for a loved one if they had this problem. And we have to remember that each modality, HD versus PD, has distinct advantages over disadvantages, and there are submodalities as well. So physicians should be as explicit as possible describing these trade-offs and trying to help the patient make this very difficult decision. So I'm going to go through these slides. It's one more study talking about one of those healthcare professionals that chose more home modality, PD and HD, home HD. And now we're arriving at question 3, a very important question. Which one of the following patient characteristic or comorbidity associates with a better overall outcome on dialysis? And the answer is residual urine output. So over 500 cc's a day of urine output, it's a considered significant urine output. And that brings us to the idea, when should we start patients on dialysis? It's a very hot debated topic right now. Even 10 years ago, we had this Australia and New Zealand study called IDEAL study, published in New England, and that showed that a late start with a GFR of 5 to 7 is non-inferior to an early start of GFR of 10 to 14. A lot of practices were incentivized to start early by certain payment models and Medicare. It's really, some people started patients on dialysis with GFRs above 20 in certain states, and that was almost scandalous at one point. That was obviously wrong, 20, 25, 10, 15, 20, it's a GFR that, you're putting these patients on 3 times a week dialysis for a number of years with a very low GFR. You're destroying that GFR due to their decline, inevitable decline in GFR, rather than giving them another few years free of dialysis and putting them on when they really exhibit symptoms of a GFR of 5 to 7. So that was the conclusion of this study. So it was a practice-changing study. We're starting them late, starting at that point, later. Of course, there are critics of that, saying that, some patients are non-compliant and they have to be started early, or else they have a very high risk of death, but not showing up and not realizing that they're uremic, etc. So there is a little bit of increased attention and very frequent follow-ups when the GFRs are this low. We need to really be proactive and make sure we select the best patients for that type of start. And so the implications are pretty vast of this study. Okay to delay initiation to GFR of 7 to 10, and dialysis initiation should be based on symptoms rather than GFR alone. So why is this residual function so important? It does a lot of metabolic work. The kidney does a lot of metabolic work. I mentioned a few. I mentioned those OAT and organic anion and cation transporters, mentioned this active secretory processes, as well as detoxification, glutamine metabolism, EPO production, etc. So this remaining GFR is incredibly helpful. Plus facilitate regulation of fluid, and so that's very, very helpful for people with CHF. This is just a study by Shafi at Hopkins that shows that this is the all-cause mortality in 600 patients, hemodialysis patients by urine status at 1 year. The trouble is this study measured residual urine output. We don't measure that, and it's not mandated. In PD, we have mandatory measurements every 3 months of the urine output in CKD patients, but that is not obligatory and is basically not done in hemodialysis patients, which are 92% of our dialysis patients. So unfortunate, but when you do it, you see that the all-cause mortality clearly the curves separate very early. Yes, persistent urine output, no. Loss of urine output, much higher mortality or hazard ratio for them. So very interesting. We are very big in this practice on preserving residual renal function. And you know, there is a few centers around the world now that advocate a gradual or incremental start of dialysis. Very, very short, 1 minute, I wanted to say a word about that. What it means is that instead of starting 3 times a week dialysis, in patients that are qualified, and I cannot emphasize enough, patients that are well qualified for that, very compliant, very motivated patients and intelligent patients, they could be explained that they could start an extreme diet with once a week dialysis. Even if they are uremic, we can start once a week dialysis with an extreme diet, or twice a week dialysis with a less extreme diet for a while, and that will prolong the residual kidney function. We think of this approach as something that will provide this magic benefit of residual kidney function versus just putting them on 3 times a week dialysis from get-go, from the outset, and having that function destroyed through many relative hypotension episodes, drop in blood pressure during dialysis that really cause a ATN, repeated episodes of ATN, and destruction of that residual tubular function. So try to avoid, the take-home lesson is try to avoid nephrotoxins if your dialysis patient still makes urine. And contrast, etc. So we have quite a bit of awareness of that, and we have always these questions come from you guys. We appreciate that, and from the emergency room. So we try to avoid if possible. And once again, MRI contrast is not a nephrotoxic. So if they ask you, can we do an MRI with gadolinium? Yes, that is not nephrotoxic. And moreover, there are studies showing that it's not causing that scleroderma type disease in the skin. So it's almost zero. There's basically zero incidence over the last 5 or 6 years in the world. There's no case of scleroderma from contrast, MRI contrast. So we have a protocol where we still dialyze them after that, but I prefer that MRI contrast and 1 dialysis session after, rather than exposing them to IV contrast, a CAT scan, iodinated contrast.